The knee hurts on stairs. The lower back aches after standing for 20 minutes. 2 symptoms. 2 appointments. The orthopedist examined the knee. The physiotherapist examined the back. Neither examined the shoe. The knee specialist prescribed anti-inflammatories and recommended quadriceps strengthening. The back specialist prescribed stretches and recommended core work. Both treatments addressed the symptoms at their endpoint. Neither treatment addressed the input at the origin. The quadriceps strengthening helped the knee absorb load better. The core work helped the spine stabilize under the lordotic posture. Both interventions improved the capacity to tolerate the compensatory loading. Neither intervention examined whether the compensatory loading was necessary, whether removing the mechanical input that drove the compensation would resolve the symptoms the compensation produced. Pick up the shoe you walked in today. Look at it from the side. The heel is higher than the toe. Measure the difference, 10 to 15 millimeters in most trainers, 12 on average. You have been standing on a wedge for 50 years. The measurement takes 10 seconds. Place the shoe on a flat surface. Measure the thickness at the heel. Measure the thickness at the toe. Subtract. The difference is the heel-toe drop, the number the shoe industry calls drop, and the number your joints have been compensating for since the first pair of shoes with a raised heel went onto your feet. Running shoes average 12 millimeters. Dress shoes average 20 to 40. Work boots average 15 to 20. The flat shoe you believed was flat carries 10 to the heel-toe drop that you never measured because the geometry is invisible from above. The wedge tilted the ankle. The tilted ankle changed the knee. The changed knee shifted the pelvis. The shifted pelvis deepened the lumbar curve. 5 joints altered by a heel elevation you never measured, and the shoe manufacturer never mentioned. The knee that hurts on stairs and the back that aches after standing are 2 symptoms of one mechanical chain ascending from the same elevation. The orthopedist treating the knee and the physiotherapist treating the back are addressing 2 consequences of one cause, neither examined. The cause is below both their examination tables. 12 millimeters, a number smaller than a fingertip width, a number that changed the geometry of every joint above it for 50 years. What does the heel drop do to the ankle? Heel drop holds the ankle at approximately 85 to 87 degrees instead of the neutral 90. A plantar flexion of 3 to 5 degrees, small enough that you have never noticed it, sustained for every minute you wear shoes, every day for decades. The gastrocnemius soleus complex, the calf muscle group that crosses the back of the ankle, sits in a chronically shortened position whenever the heel is elevated. Over months and years, the muscle tendon unit remodels to the shortened length. Collagen fibers in the Achilles tendon rearrange to the position the heel holds them in. The remodeling is adaptive. The tissue adjusts its resting length to match the environment it operates in. The same Hooke's law adaptive mechanics that govern every tendon in the body. The tendon that should provide 15 to 20 degrees of dorsiflexion, the shin toward toe motion the ankle needs during walking, now provides 5 to 10. The ankle lost half its upward range because the shoe held it in a shortened position for 30 years, and the tissue adapted to the position the shoe imposed. You can test this now. Stand barefoot on a flat surface, keep both heels on the ground, and try to squat fully. If your heels lift before your thighs reach parallel, your dorsiflexion is restricted. The depth at which the heels lift is a rough measure of the range the gastrocnemius adaptation has cost you. Most adults over 50 who have worn standard shoes their entire lives cannot achieve a flat-footed squat because the ankle cannot provide the dorsiflexion the movement requires. The restriction is tendon adaptation to a shoe geometry that held the ankle in plantar flexion for decades. A clinical dorsiflexion test is more precise. Kneel on one knee, place the other foot flat on the floor in front of you, and push your knee forward over the toes while keeping the heel flat. Measure the distance from the kneecap to the wall, or the angle of the tibia. Less than 10 degrees of forward tibial travel indicates restricted dorsiflexion. Repeat the test with the knee bent, kneel and push the knee forward while keeping the heel flat. If dorsiflexion improves with the knee bent, the gastrocnemius is the primary restrictor because the gastrocnemius crosses the knee joint and slackens when the knee flexes. If dorsiflexion stays restricted with the knee bent, the soleus is also involved because the soleus sits below the knee and its length does not change with knee position. The test tells you which muscle the shoe shortened and which stretch protocol targets the correct tissue. The number tells you how much range the gastrocnemius adaptation has cost you. If you can push the knee 10 centimeters past the toes with the heel flat, your dorsiflexion is adequate. Less than 5 centimeters indicates significant restriction. 0 centimeters, the heel lifts the moment the knee moves forward, indicates severe adaptive shortening that has likely been driving compensatory mechanics at the knee and above for years. The number predicts how much compensatory stride extension your walking pattern has been producing at the knee. Walking requires dorsiflexion. During the stance phase of gait, as you push off and your body weight moves forward over the planted foot, the tibia must rotate forward over the ankle. This forward rotation is dorsiflexion. The ankle needs 10 to 15 degrees of dorsiflexion to allow the tibia to travel forward naturally. When the shortened gastrocnemius restricts the available range to 5 degrees, the stride cannot complete through the ankle. The body compensates at the next joint up. The compensation is involuntary. You do not choose to extend the stride. The stride extends because the ankle cannot provide the dorsiflexion the normal stride pattern requires, and the motor control system finds the available range by reaching the foot further forward, bypassing the ankle restriction by using knee extension and hip flexion to achieve the step length the restricted ankle cannot support. The compensation is invisible to you. You walk normally from your perspective. The force plate and the gait analysis camera see the compensation the ankle restriction produces. Ankle restricted. Stride must continue. The compensation moves to the knee. How does the restricted ankle load the knee? 2 separate loading patterns on the same joint from the same ankle restriction, each one producing a different symptom. Now, loading pattern 1, impact. Limited dorsiflexion forces a compensatory stride extension. The foot reaches further forward at initial contact because the ankle cannot provide the range the shorter stride would require. The foot lands ahead of the body's center of mass. Heel strike. The heel contacts the ground with the leg extended, the quadriceps inactive, and zero muscular cushioning absorbing the load. Force plate studies show a characteristic impact transient at heel strike, a sharp spike of force lasting approximately 50 milliseconds, rising to 1.0 to 1.5 times body weight before the muscles can activate to absorb the load. The transient is the force the joint absorbs before any muscular response can engage. The cartilage compression from this 50 millisecond spike is the loading event that repeats 1,200 times per mile, and the cartilage receives the full transient each time because the muscles cannot activate fast enough to cushion it. Articular cartilage is approximately 70% water held within a matrix of type 2 collagen fibers and proteoglycan molecules. The water provides the hydraulic cushioning. Under compression, water is squeezed out of the matrix, absorbing the force, then slowly drawn back in during the unloading phase by the osmotic pressure the proteoglycans generate. Each impact compresses the water out. Each recovery draws it back. The cycle works within a loading range the matrix can sustain. When the loading exceeds the range, the water is squeezed out faster than the osmotic pressure can draw it back, and the matrix dehydrates progressively, losing the hydraulic cushion that protects the underlying bone. The dehydrated cartilage is stiffer, less compliant, and transmits more force directly to the subchondral bone, which responds by thickening and sclerosing. The bony change is visible on the X-ray years after the cartilage loading pattern began. Ground reaction force at heel strike, 1.0 to 1.5 times body weight. For an 80 kilogram person, 800 to 1200 newtons transmitted through the calcaneus, up the tibia, to the knee joint. The force vector at heel strike passes through the knee, loading the medial compartment, preferentially 60 to 70% of total load on the inner side. The medial compartment, the inside of the knee, absorbs the majority of every heel strike. The asymmetry exists because the force vector from heel strike passes medial to the knee's mechanical axis, creating a varus moment that drives the tibia inward relative to the femur. The varus moment concentrates loading on the medial side. Over 13 million cycles per decade, the concentrated loading produces asymmetric cartilage where the medial compartment thins while the lateral compartment remains relatively preserved. The asymmetry is the early pattern of medial compartment osteoarthritis, the most common form of knee arthritis in the 60-plus population, and the asymmetry traces through the force vector to the heel strike the ankle restriction produces. The lateral compartment, the outside of the knee, is partially unloaded. The concentration is consistent and directional. Every heel strike produces the same medial bias because the force vector geometry at heel strike is the same on every step. Arithmetic: 1200 heel strikes per mile, 3 miles of daily walking, 365 days per year, 1.3 million impacts per year on the medial compartment, 13 million per decade, each impact compressing medial cartilage at 800 to 1200 newtons without muscular attenuation. The teeth discussion described Paris law fatigue, cyclic loading below the single event failure threshold, producing cumulative damage through millions of repetitions. The same mathematics applies to the medial knee cartilage. No single step exceeds the cartilage's acute failure strength, but 13 million cycles per decade propagate fatigue damage through the matrix at rates proportional to the load magnitude and the cycle count. The X-ray that looks fine but the knee that hurts is cartilage compression fatigue below imaging resolution. Articular cartilage has no blood supply. It receives nutrients through compression and release, the fluid exchange that occurs when load is applied and removed during walking. Chronic high-impact loading at heel strike compresses the medial cartilage at forces that exceed the optimal range for nutrient exchange, squeezing the matrix harder and faster than the recovery phase can replenish. The cartilage degrades not because it wears out from friction, but because the loading pattern exceeds the biological maintenance capacity of a tissue that depends on measured compression for its survival. Heel strike produces a transient impact peak absent from forefoot and midfoot strike patterns. Lieberman and colleagues measured these forces in nature. I trace my own knee pain to the heel drop arithmetic, the week the force plate data replaced the word aging in my understanding of the medial ache on stairs. 13 million impacts per decade at 800 to 1200 newtons on a cartilage surface designed for distributed loading through muscular deceleration, receiving the full impact structurally because the ankle restriction forced the heel strike that bypassed the muscles. The cartilage was fatigued. The knee was not old. The knee was loaded. What does the restricted ankle do to the knee beyond impact? What is the second loading pattern the restricted ankle produces? Restricted ankle produces a second knee compensation simultaneously, one that loads the opposite side of the joint. Now loading pattern 2, hyperextension. When the tibia cannot rotate forward over the ankle because dorsiflexion is blocked by the shortened gastrocnemius, the knee compensates in a different way. The tibia drifts backward relative to the femur during stance, producing 3 to 5 degrees of hyperextension beyond the neutral position. The knee that should sit at 0 to 5 degrees of flexion during standing extends past 0 into hyperextension. Chronic hyperextension loads two surfaces simultaneously, and the loading is cumulative with standing time. Every minute of standing adds another minute of hyperextension force on both surfaces. A job that requires 4 hours of standing per day produces 4 hours of chronic hyperextension loading on both the posterior capsule and the patellofemoral joint, daily for years. The posterior capsule, the ligaments and capsule at the back of the knee, stretches under the hyperextension force. The patellofemoral joint, the kneecap tracking surface on the front of the femur, compresses as the kneecap is pulled tighter against the femoral groove by the altered mechanics. Pain behind the knee during prolonged standing is the posterior capsule stretching under chronic hyperextension. Pain under the kneecap on stairs is the patellofemoral compression from the same hyperextension. Two different knee complaints. One, ankle restriction. If you report both, a dull ache behind the knee during prolonged standing and a sharp pain under the kneecap on stairs, you are describing two consequences of one mechanical compensation, both traceable to the dorsiflexion the shoe took away. Patellofemoral contact pressure responds to tibial position and knee extension angle through calculable lever arm changes. Powers described these mechanics in the Journal of Orthopedic and Sports Physical Therapy. Ankle restricted, knee absorbs the impact and hyperextends. The cascade has loaded two joints. The body's center of mass, shifted forward by the heel elevation, now requires a third compensation at the pelvis. How does the heel elevation tilt the pelvis? Elevated heel shifts the body's center of mass forward, standing on a 3 to 5 degree downhill slope perpetually. To prevent falling forward, the pelvis tilts anteriorly, the front of the pelvis drops, the back rises. 4 to 8 degrees of anterior pelvic tilt from the heel elevation, measurable through gait analysis and postural assessment. You can observe this on yourself. Stand sideways in front of a mirror in your shoes, then remove the shoes and stand barefoot. The change in your lower back curve is visible. The belly that protrudes slightly more in shoes is the anterior tilt, pushing the abdomen forward. The lower back that hollows more in shoes is the lordosis deepening. The postural change is immediate and reversible. It appears the moment the heel goes on and disappears the moment the heel comes off. The chronic version is the 30-year adaptation the tissue has made to the posture the heel maintains. Anterior pelvic tilt increases lumbar lordosis. The inward curve of the lower back deepens. The geometry is specific. Each degree of anterior pelvic tilt produces approximately 1 degree of increased lumbar lordosis. 4 to 8 degrees of tilt from the heel elevation produces 4 to 8 degrees of additional lordosis distributed across the 5 lumbar vertebrae, with the greatest increase at L4, L5, and L5S1, where the lordotic curve is sharpest. The increased lordosis compresses the facet joints at L4, L5, and L5S1, small paired joints at the posterior aspect of each vertebral segment that guide and limit spinal motion. Under increased lordosis, the facet surfaces bear continuous compressive load during standing and walking. Surfaces designed for intermittent contact during occasional extension now loaded chronically under the postural shift. The facet surfaces are covered with articular cartilage approximately 1 to 2 millimeters thick, thinner than the knee cartilage that bears 3 to 5 millimeters. The thinner cartilage tolerates less chronic compression before the underlying subchondral bone begins remodeling in response to the sustained load. The remodeling, visible on CT as facet hypertrophy or sclerosis, is the joint's structural response to a compressive load it was designed to bear intermittently but is now bearing continuously. Facet joints at L4, L5, and L5S1, the two most common sites of non-discogenic lower back pain. If your back aches specifically after standing, not sitting, not walking, but standing still for 15 to 20 minutes, the positional specificity is the diagnostic clue. Standing loads the facet joints under the lordotic posture the heel elevation drives. Walking reduces the load because the dynamic motion cycles the facet contact. Sitting eliminates the lordotic posture entirely. The complaint that is worse during standing and better during walking or sitting points directly to facet loading from anterior pelvic tilt driven by the drop in the shoes you wore today. The MRI that shows normal discs but the back that still hurts after standing may be facet compression from the postural shift the heel drop produced. The disc herniation discussion described pain from the disc under flexion loading, the nucleus pushing posteriorly when the spine bends forward. Facet joint pain operates through the opposite mechanism. Extension loading, increased lordosis from anterior pelvic tilt compressing the posterior joint surfaces. Opposite mechanism. Same lumbar segments. Both traceable to mechanical causes you can modify. Heel elevation produces measurable increases in lumbar facet contact pressure proportional to the resulting anterior pelvic tilt. Kerrigan and colleagues documented this in the American Journal of Physical Medicine. Facet loading under lordotic posture follows calculable compression mechanics. McGill established these mechanics in low back disorders. My understanding of the two specialist problems shifted the afternoon. The ascending chain reached the lumbar spine from the shoe. The orthopedist looked at the knee. The physiotherapist looked at the back. Both were correct in what they found. Neither looked down. The knee pain and the back pain both ascended from the ankle restriction, the 12 millimeters produced, through a mechanical chain neither specialist examined because the cause sat below both their examination windows. One input, 5 joints. 2 symptomatic endpoints treated as separate problems by separate specialists examining everything except the shoe. The orthopedist ordering the knee X-ray does not measure heel-toe drop. The physiotherapist assessing lumbar mobility does not test ankle dorsiflexion. The podiatrist evaluating the foot does not examine the lumbar spine. Each specialist examines their segment of the chain. The chain connects all 5 segments through the drop, none of them measured. The frustration of receiving 2 separate diagnoses for what you experience as one problem, the sense that the knee and the back are somehow connected but no one has explained how, resolves through the ascending cascade. Both symptoms originate from the same mechanical input and propagate through a traceable anatomical chain that connects the shoe to the spine through 5 joints in sequence. Can the chain be reversed? Graduated transition. The shortened gastrocnemius needs time to lengthen. The tissue that remodeled to the shortened position over 30 years of heel elevation must remodel again to the longer position. Abrupt transition from the current drop to a zero-drop shoe loads the Achilles tendon at a length that has not experienced in decades. Well, the tendon remodeled to a shortened position is suddenly asked to sustain full dorsiflexion range under bodyweight loading. The collagen fibers oriented and cross-linked for the shorter length bear forces at angles and magnitudes the remodeled tissue cannot accommodate. Achilles tendinopathy, the inflammatory response to overloaded tendon tissue, is a documented risk of sudden minimalist shoe transition in adults over 50 whose tendons have decades of adaptive shortening. The transition must be gradual, 8 to 12 weeks of progressive heel reduction. Start at the current drop to 8 for 2 to 3 weeks, allowing the gastrocnemius to begin remodeling to the new length. Drop to 4 for 2 to 3 weeks, drop to 0. At each step, monitor the Achilles for tenderness, the calf for excessive tightness, and the ankle for the dorsiflexion increase that confirms the tissue is lengthening. Supplement the shoe transition with daily gastrocnemius stretching, sustained holds of 30 to 60 seconds, not bouncing, allowing the tissue to creep to its new length under gentle sustained tension. Each step sustained for 2 to 3 weeks, allowing the gastrocnemius tendon unit to remodel incrementally to the new length. The muscle adapts in 4 to 6 weeks because myofibrillar protein turns over with a half-life of approximately 7 to 15 days, allowing the muscle to add sarcomeres and lengthen relatively quickly. The tendon adapts in 8 to 12 weeks because mature cross-linked collagen turns over far more slowly, with fibroblast-mediated collagen synthesis replacing old fibers at a rate measured in months rather than weeks. The tendon feels ready at week 6 because the muscle has adapted. The collagen has not yet remodeled to the new length, and the 12-week protocol respects the tendon's slower biology. Remodeling follows the same adaptive mechanics that caused the restriction. The tissue that shortened in response to chronic heel elevation lengthens in response to chronic lower elevation. The same biology running in reverse. The tendon that shortened by adding crosslinks at the shortened position lengthens by adding new collagen at the lengthened position, gradually shifting the tissue's resting length toward the geometry the lower heel demands. The remodeling rate is approximately 1 to 2% of total tendon length per week under sustained new length loading, which is why the 8 to 12-week protocol is necessary. Faster transitions exceed the remodeling rate and produce injury. The ankle recovers dorsiflexion range incrementally as the tendon lengthens. The recovery is measurable. The dorsiflexion test you performed at the start of the transition should show progressive improvement across the 8 to 12-week protocol. Each additional degree of dorsiflexion the ankle recovers is a degree of compensatory hyperextension. The knee no longer needs to produce. A degree of medial impact the stride no longer generates. A degree of anterior tilt the pelvis no longer requires. A degree of facet compression the lumbar spine no longer absorbs. The chain unwinds in the same anatomical sequence it wound up, joint by joint, from the ankle upward. The stride shortens naturally as dorsiflexion returns. The foot begins landing under the center of mass rather than ahead of it. In zero-drop shoes with recovered dorsiflexion, the foot lands at midfoot rather than heel. The foot contacts the ground with the ankle in slight plantar flexion, the knee in slight flexion, the hip in slight flexion, the entire lower extremity preloaded for eccentric deceleration. The landing position activates the stretch reflex in the gastrocnemius, quadriceps, and gluteal simultaneously, engaging all 3 muscle groups in a coordinated deceleration that absorbs the impact energy over a longer time window than the 50 millisecond spike heel strike produces. The deceleration window extends from approximately 50 milliseconds at heel strike to approximately 200 milliseconds at midfoot strike, 4 times longer, distributing the same impulse across a wider time base and reducing the peak force proportionally. At midfoot strike, ankle, knee, and hip flex simultaneously, 3 joints sharing impact through eccentric muscular deceleration rather than structural absorption. Peak impact force drops approximately 30 to 50% compared to heel strike because the eccentric muscle contractions absorb the energy that heel strike transmitted directly to the joint surfaces. The gastrocnemius decelerates the ankle. The quadriceps decelerates the knee. The gluteals decelerate the hip. 3 muscle groups sharing the load that heel strike delivered to one joint surface. The impact is distributed across active tissue that can absorb, adapt, and recover, rather than concentrated on passive cartilage that can only compress and slowly rebound. Medial compartment loading decreases. Patellofemoral compression decreases. Posterior capsule stretch resolves. Anterior pelvic tilt reduces. Lumbar facet loading decreases. Whether your specific knee or back symptoms require clinical evaluation, imaging, or intervention beyond footwear modification is a determination your physician or physiotherapist makes through examination. The physics teaches how 12 millimeters propagates through 5 joints. The clinician determines what your specific symptoms require. The physics described in this section does not diagnose your knee pain or your back pain. Knee pain has multiple causes. Back pain has multiple causes. The heel elevation is one mechanical input into a chain that may or may not be the primary driver of your specific symptoms. What the physics provides is a mechanical variable you can measure, modify, and observe across 12 weeks. If the symptoms improve as the heel drops and dorsiflexion recovers, the chain was contributing. If the symptoms persist unchanged, another cause is primary and the clinical evaluation continues. The shoe had a 12 millimeter heel you never measured. The heel shortened the calf. The shortened calf restricted the ankle. The restricted ankle extended the stride and hyperextended the knee. The extended stride produced heel strike at the per mile impact count on the medial compartment. The hyperextended knee compressed the kneecap and stretched the posterior capsule. The elevated heel tilted the pelvis forward. The tilted pelvis deepened the lumbar curve. The deepened curve compressed the facet joints. 2 symptoms: knee pain and lower back pain, treated separately, ascending from the heel elevation. Removing the heel elevation gave every joint above it the geometry it was designed for.